I'm hoping that my presentation will very much complement what Gillian has been saying, and there will be some overlap between the two. So I'm going to be referring to an entire project called Clinical Care in Crises and another entity called Frontline. And Gillian made reference to SMART guidelines, which is a whole initiative within WHO to enable digitalization of what have been paper-based guidelines. This particular work focused on the humanitarian settings in child health. And so hopefully it'll complement very much what Gillian has been sharing. I'm going to talk about that work, and there'll be some overlap, but I also want to make some reference to what we refer to as the fire standards. I see a typo already, and interoperability. A short period of time on what I refer to the shop front and the L3, the layer 3, and then a couple of evidence gaps and research needs, which I'm very conscious this day is very much focused on research. So clinical care in crises is a project within WHO. It's a collaboration between 5 different departments, started in late 21, and between ourselves and digital health, IMT, the science division, and our nutrition colleagues. And the reason for focusing as much as Gillian was referring to child mortality and newborn mortality, it's also a fact that about 50% of maternal, newborn, and under 5 mortality is now occurring in humanitarian settings, a place where access is often very challenging and difficult. And Gillian made reference to WHO guidance, but very commonly, the guidance that we have is not actually adapted or even tested in those emergency or humanitarian settings. So it's a real blind spot and a challenge for us. And so there are a number of different ways in which narrative guidelines have limitations. And I'm just going to make a brief reference to those. So just from the outset, to understand that the overall project name is Clinical Care in Crises, but we do have an app that we refer to as Frontline. And sometimes I will jump between these two. So forgive me if I do, and you will understand the difference between them from the beginning. And just to acknowledge the Fondation Botner, although we have funding from several sources, we're very grateful to the Fondation for the support. So with narrative guidelines, so paper-based guidelines, what we see, and we've known this for years, is that there are time delays between updating and getting information out to health workers. And that has a consequence that patients are denied access to the best quality care. Sometimes this also means that there's diminished accuracy because guidelines get outdated, and things like decision tools don't get updated in the more remote and less accessible facilities. So services are compromised. It's very difficult to evaluate and adapt these guidelines whenever they're out because of the same reasons. And for that reason, there's limited opportunity to improve practices. And, fundamental to this is the difficulty with dissemination to all settings within a country or in a regional area. And so it's always difficult to think that the impact is going to be taken to scale. But before going further and before I forget, I really want to agree with, there was a question raised, and we'll come back to it about time, and Gillian made reference to quality. Digitization of clinical decision tools is not a silver bullet. It can be helpful in some settings, but it really brings into focus the tension of delivering quality at scale. And there is a tension to be aware of and to find a solution to, that quality care takes time. And so as much as our experience with digital tools at the moment is that they increase the time requirement, the reality is that quality care often takes longer than time available on any one given day. So the vision behind clinical care in crises and Frontline as part of that is to improve health outcomes in emergencies by making WHO established clinical recommendations available whenever, wherever, and by whomever. So it's to, in that sense, to reduce inequity by enabling the best quality practices to be extended to all populations, no matter. So smart guidelines, that is it's just a placeholder word for the entire effort that's going on within WHO to make normative guidance available as digital solutions. In this instance, we refer to Frontline as the app. So for the health worker, we're hoping that it would improve the speed and accuracy of diagnosis at the point of care. It would add confidence to the health worker that the clinical care is founded on WHO recommendations and enables easier provision of continuity and follow-up. For the patient, theoretically, it would mean that there's greater assurance that they're receiving the right care. And for ministries of health, it means that it would support what is already happening in many settings, and that is digital health strategies. So it's not just an app, and in fact, that is probably the lesser emphasis for us, but it is actually the underlying requirements documentation and what Gillian correctly referred to as standard-based machine-readable codes. So this is the same layer 1, 2, 3, 4, 5 that Gillian was referring to. The layer 1 is the narrative guideline, that is the paper-based recommendations, things like IMCI. The layer 2 is when these are taken into business flows, and we'll see some examples in a moment. Into L3 is open source software coding. 4 is whenever it's taken into an executable tool like an app. And then 5 is this machine learning opportunity for using the data coming out of it to have. So that's the theory of it. For clinical care in crises, and we have the collaboration started in 21 with a whole set of foundational work, including adaptation of IMCI for emergency settings. In 2022 and 2023, we had the development of the layer 2, and I'll show you some examples of that at the moment. The layer 3 was then the conversion of those business tools or those business flows into software coding. Layer 4 was happening in parallel, the development of an app that would execute the software coding. And layer 5 is something to be discussed in the future. So very briefly, this is another example of what Gillian was showing. This is a typical chart within IMCI about the care of malaria. And when you take that from an algorithm that people have on their desk in a chart booklet or a poster, then we convert those into business flows. And so these are all individual decision points that are taken. And this is what the software or the coding team would put into open source coding. Alongside that, there's the documentation. And I really do want to emphasize this because I came at this as a clinician. I had so it's been a steep learning curve for me. But what I have really appreciated is that what's ultimately probably the most important aspect of this is the underlying documentation, the definitions, so that anything and everything that is ultimately included within a coding has a reference and a definition, which means that at any point in time in the future, if there is a change in recommendation, for example, when antibiotics are given for an infant with a particular respiratory rate, if a guideline changes to say that the threshold for giving an antibiotic changes, that instead of being a respiratory rate of 60 breaths per minute, it is now 80 breaths per minute, then you can track the exact place throughout the business flows and the documentation where that change needs to occur. So this underlying documentation and standards, which is what we refer to as the FHIR, or partly refers to as the FHIR, is absolutely pivotal for any subsequent coding and any subsequent mobile app. And this is actually where the the detail is in terms of the work and what takes often so much time. Gillian referred to the work that was done, and we were hugely appreciative to the team at Swiss Tropical for their support in this. It would simply never have happened had it not been for them. But ultimately, we went through the translation of IMCI through these steps of the business flows, the layer 2, into the coding, all the documentation, and ultimately it was then implemented through an app that was developed in parallel through Frontline. And so we had this pilot in Iraq, and Gillian was part of that. And the objective of that pilot was to assess the feasibility and usability of the app in that particular setting. It was a mixed methods, observations, collection of consultant data, and then user feedback. And it was done last year. It wasn't large. So this is very much a pilot, and it doesn't have p-values or anything beside it. But this is an example of the health worker using the app along with the mother and young infant, going through the various decision pathways, exactly the same steps as we find in IMCI, but exactly the same as Gillian shared, where you were taken through a pathway, you're obliged to answer things, and ultimately that takes you to a classification and a recommendation as to whether an antibiotic or other care should be given. This is just a little bit of the feedback. So it was, in total, there were almost 600 consultations assessed over a number of weeks. So that by itself, it wasn't the largest, but it wasn't small either. Just some of the headline messages: 80% of the health workers found the app easy or very easy to use. They felt comfortable with it generally. They found it generally useful in their support for providing care to sick infants and children. They believed it was feasible to implement Frontline in routine practice. They trusted the underlying classifications, and they strongly trusted the treatments being given. And importantly, the caregiver, the one receiving the care, they also felt very comfortable with the healthcare worker using the app during the consultation. In terms of the types of children coming through the door, so the question about, is this a management tool or a prevention tool? This work is definitely about management. But as Gillian said, we are now looking at how to take this into well child visits, which would therefore be a much shorter and much more succinct and focused set of messages. So these children were assessed for all danger signs. So we see the difference before and after, the left-hand column, going from 32% to 85%, 68% to 70 or 78%, weight being measured going up from 2/3 up to almost 100%. It's never sure whether this would be sustained over time, but certainly these signs were encouraging. In terms of the problems reported, 40% of health workers did report a problem, and we shouldn't be sort of trying to conceal that. The most common difficulty was the time factor. It took 2.5 minutes longer to have a consultation than it did without the app. And there were some classifications that weren't included in Frontline, and that was because this was a pilot. On occasions, the health worker didn't agree with the classification, and those are the sorts of things that we need to iron out over time. Overall, the main findings, the feedback was generally positive. It was easy and feasible, and they trusted it. The key issues were the speed of the application, synchronizing of the data from the phone to the server, and there were some, as I said, technical issues that we need to identify. For the high priority areas for improvement was to include other aspects, weight-based dosing, which are all in process at the moment. So those discussion points very much complement everything that Gillian shared earlier. I want to share really just 3 points now. And the first is about this issue of standards-based development. And essentially, the standard that WHO is requiring and having as part of this guideline is to use this fast health interoperability resource. And essentially, this is just a series of requirements, definitions being properly documented, the business flows certainly being there. And this standards-based architecture of everything that follows, the layer 2, the layer 3, the app itself, they create a set of resources that can be used elsewhere and enable interoperability with other systems. So things like DHIS2, et cetera, et cetera. The importance of this term interoperability, I think, is easy to miss, but it will enable what the health worker at the front line is using to link with a whole set of other systems benefits sitting behind it. It means that things like facility attendance by age and illness can be captured almost real time. These numbers can go to a district office almost immediately. It means that you can estimate and see morbidity profiles almost real time. It would potentially allow you to see an outbreak alert because you're seeing many more children of an age presenting with diarrhea. It allows you to calculate and see immunization uptake and coverage. It allows you to track drug usage and to link in with supply chain management. That's what the standards and the interoperability sell. And so there may be a number of reasons why health systems actually insist that the frontline health worker use this, because there are many advantages sitting behind the application for the health system, rather than just whether it helps the primary health worker delivering the care. It means that there's the potential of linkages between facilities and the district. It allows potential linkages between the facility and home-based records. And it also allows the potential updating of clinical decision tools almost remotely. You wouldn't necessarily have to go and upload it on the phones. The system could actually do that automatically. But it also, we should recognize the other problems. It increases the need for data security, and there are many challenges related to that. I made reference to what we call the shop front, which is the L4. That's the app. That's what you see. So WHO has this app called Frontline. But the truth is that the major asset is actually the L3 content. And because it's open source, because it's followed these standards, it can be uploaded and used in any other application, any other app that is able to use open source language and coding. It can directly introduce and bring this into that app. So many national authorities have their apps already. They don't need a WHO app, but they can absolutely bring in and import everything that is being developed through clinical care and crisis into their application. And that's the real strength. The L3, kind of the backroom content, which is actually the major asset of all. There are many evidence gaps and therefore research needs. Gillian referred to the difference between Kenya and Tanzania, for example, in terms of change in practice. We need to understand what facilitates or optimizes use of these digitalized clinical decision tools. We need to understand, do they actually improve the accuracy of classification? Is coverage and our health outcomes improved through the use of these tools by health workers? And ultimately, is there an opportunity for machine learning, once we get large volumes of data come in, to actually improve the accuracy and performance of these decision tools when used by health workers? So for WHO, our steps now are to promote the uptake of this L3 content. And here we're looking to build coalitions amongst communities, to scale up existing pilots, and to maintain Frontline L4 app. We're wanting to expand the clinical content beyond what we have at the moment to include things like early childhood development, to bring in advanced treatments like asthma, diabetes, and to adapt this for the routine setting. And lastly, to contribute to that overall digital health environment at national level promoting the FHIR standard, and also demonstrating how standards can interact and operate with other system functions. So thank you very much indeed for the chance to share this with you, and look forward to a few moments of discussion. Thank you very much.